Live.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to this educational activity, and the topic of today is about hyponatremia management in 2020. We'll start talking from the physiology to clinical implication. I have one disclosure that this activity is sponsored and organized by SPIMACO الدوائية. These are the outlines of my talk. I will talk briefly about the history of hyponatremia, clinical importance of the hyponatremia, the pathophysiology of hyponatremia, diagnostic approach to hyponatremia, and then I will go to the treatment, and I will touch about the use of Vaptan in hyponatremia treatment, and I will end about what we can conclude from registry data. Hyponatremia is not a new topic. So in 1926, water intoxication, it was attributed at that time to ingestion of water that lead to cerebral edema. They don't know at that time that it is related to hyponatremia, but they call it at that time water intoxication. 1935, water intoxication, that's supposed to be the hyponatremia, it was discovered that can be treated with hypertonic saline, although the pathogenesis at that time, it was not clear. 1938, self-induced water intoxication resulting in edema, coma, and convulsion. 10 years after that, complication after IV absorption of distilled water. So it was discovered that dilute the blood and causing hyponatremia. But the discovery of the measurement of serum sodium by the flame photometry was in late 40s. 1957, Schwartz and his group, they discovered the syndrome of inappropriate antidiuretic hormone, and it was described at that time in patients with bronchogenic carcinoma. 1963, Wright and his group, they found hyperglycemia-induced hyponatremia, and they describe it at that time. 1976, the talk about acute versus chronic was addressed at that time. 1980s reported the first use of oral urea for the treatment of brain swelling, brain edema, and that result in increased water excretion. 86, hyponatremia in marathon runner in Boston Marathon, it was described. In the same year, also the description of post-surgical hyponatremia. In 1989, it was the first report of central pointile myelinosis, what we call it for the time being, osmotic demyelination syndrome, and it was related to rapid correction of hyponatremia. 2001, identification of the mechanism of exercise-induced hyponatremia. In 2005, Fliedman published a paper in New England Journal of Medicine described a case of 2 infants that they have hyponatremia and they have undetectable antidiuretic hormone, and they call it nephrogenic syndrome of inappropriate antidiuretic hormone secretion. Vaptan's Convaptan, that was the first antidiuretic hormone antagonist approved in 2005, followed by tolvaptan that was approved in 2009. And in 2014, we have the most recent guideline that I will talk about it later. It is a guideline that was published with a combination of many groups, and nephrologists, endocrinologists, and intensive care specialists. So talking about hyponatremia. So hyponatremia by definition is serum sodium less than 135. But when it comes to the classification of mild, moderate, severe, you will find there is big variation between one guideline and another guideline. But the most commonly used classification regarding of the severity of hyponatremia, mild hyponatremia when the serum sodium between 130 to 135, moderate if it is between 125 to 130, and severe if it is less than 125, although in one study they said if it is less than 120. How common is it? You can see from this graph, if you are dealing in acute care setting with ICU, CCU, CVICU, tertiary care hospital, you can see that the prevalence of hyponatremia, when you get a sample from the lab and review it, almost in 30% of the patient. And if you are working in a clinics and you collect all the chemistry from the patient, you will find that hyponatremia, when it's defined by the serum sodium less than 135, is almost in 20% of the patient. And if you are working in polyclinic or in community hospital, it is around 7.2. So it is very common. And if you talk about secondary and tertiary hospital, is almost 1/3 of the patient, they have serum sodium less than 135. Why we talk about hyponatremia? Hyponatremia, from one study, here you can see the percentage of an increase of the cost for patient admitted with different clinical condition. So when you look to the 6-month medical cost, you can see that, on the left side, we are talking about the hyponatremia. I will ignore the hypernatremia. You can see if it is unadjusted, is around 98% increase of the cost. And after adjustment to all variables, almost 40%. And also it increased the inpatient cost by almost 2/3, 76% increase of the patient cost. The same thing for 1 year. So hyponatremia, it is very clear that associated with increase a clinical cost for the care. More important than the cost is the mortality. You can see from this curve, that's very clear that once the serum sodium start to go below 140, you can see there is dramatic increment of the mortality for these patients. Although the same when it start to go above 145, but it is more dramatic if the serum sodium drop below 135. This is from another study that will tell you that, an increase drop of the serum sodium below 138 associated with, first of all, an increase in hospital mortality. This is the number of in-hospital death. You can see that if it is less than 138, is almost the odd ratio 1.6. If less than 138 with further drop is almost 2.8. So again, just to tell you that we have more studies that will say that, hyponatremia associated with increased mortality. When you look to the second part, is not only increased mortality, but also associated with the patient more likely to be discharged to short or long-term facilities. You can see here, if it is less than 138, is around 1.1, and if there is further drop, it is around 1.9. Also associated with prolonged length of stay in the hospital, and this will be reflected by the medical cost. This table showing variable clinical condition, and you can see once the serum sodium start to drop below 135, you can see that, the ratio, let us take 125 to 129. If you take sepsis, you can see it is around 1.36. If it is 120 to 124, is around 1.6. And the same thing for pneumonia, liver disease, metastatic cancer, musculoskeletal, and respiratory system. So various conditions, if it is associated with hyponatremia, associated with poor prognosis. The same thing for patient admitted with acute ST elevation myocardial infarction. You can see that the cumulative probability of death is much higher if the patient having serum sodium less than 136. Just to summarize the outcomes related to the hyponatremia. So hyponatremia clearly associated with higher risk of mortality, associated with higher risk of discharge to short or long-term facility, and increased length of stay. Data that I did not show, associated with increased risk of fall, also associated with increased rate of osteoporosis and bone fracture, and by the end, associated with increase in the medical and inpatient cost. That's why we are talking about the hyponatremia today. So what's the possible relationship between the hyponatremia and mortality? There are a few risks. So exactly we don't know why patients with hyponatremia associated with an increased risk of death. It could be a direct effect of the hyponatremia to the human cell, leading to apoptosis and death, and this will lead to mortality. Or because of patients with hyponatremia, they have severe underlying disease, and this underlying disease causing a hyponatremia as well as causing mortality. Or hyponatremia by itself can cause organ dysfunction, and the organ dysfunction cause higher mortality. Just a speculation. So what is the pathophysiology of hyponatremia? All the time when I talk about the pathophysiology of hyponatremia, I come with this, what we call it, water cure torture. So you can find it in the Wikipedia. So the water cure torture is a form of water torture used by French, by German, Spain, Japan, and US Army, through forcing water down into the throat of the victim by putting a funnel down the throat and closing the nose, and they are pushing large quantities of water. This will cause gastric distension. This water will get absorbed, and it will cause dilutional hyponatremia, cerebral edema, and death. This is just to tell you the pathophysiology of hyponatremia-related death. So when we talk about the pathogenesis of hyponatremia, so we are talking about water disorder. If you concentrate on this equation, so the serum sodium that we are measuring for the time being, it is a ratio between the exchangeable sodium that is in the extracellular fluid and exchangeable potassium over the total body water. So that's why if there is increase in the total body water, like in most of the clinical conditions like liver cirrhosis, heart failure, and so on, patient will develop hyponatremia. Patients who have hypokalemia also, you will see later on that also they are more prone to develop hyponatremia, and I will talk about this mechanism. Briefly, I will talk about the water homeostasis. So for proper water homeostasis, we have to get 4 mechanisms. One of them, intact thirst mechanism. We have to get functioning and presence of antidiuretic hormone. You have to get functioning kidney with normal GFR, and also you have to get clear and functioning diluting segment of the nephron. I will start by talking about the ADH or arginine vasopressin. So arginine vasopressin is 9 amino acid cyclic peptide synthesized and secreted by supraoptic and supraventricular nuclei in the hypothalamus. The half-life of the antidiuretic hormone is very short. It's 15 to 20 minutes and rapidly metabolized by the liver. We have 3 types of the receptor, but for our talk, we are talking about the V2 receptors in the kidney. The 2 stimuli, major stimuli for the excretion or the release of antidiuretic hormone, we have intravascular volume depletion and we have osmotic stimuli. And you can see from this drawing on the left side that the osmotic stimuli is more potent than the intravascular volume depletion. Just 1% increase in the serum osmolarity is enough to stimulate the antidiuretic hormone, while you need 10% change in the extracellular volume to stimulate the antidiuretic hormone. Example of osmotic stimuli, we have pain, we have vomiting, we have medications. Going to the kidney. So when water gets filtered by the glomeruli, you can see that in the proximal tubule, most of the filtered sodium and water get reabsorbed here. Part of the water will pass into the loop of Henle, and then we will have the thick ascending loop of Henle. This one is very, very important part of the nephron. This is what we call it the diluting segment. That means the water will pass from here diluted. So what happened? in this segment. You can see that there is reabsorption of sodium and chloride without reabsorption of water. So what will happen if sodium chloride get reabsorbed without water? You can see that the osmolarity here will get increased. It get increased to later on pull the water from the collecting duct under the effect of V2. So that's why it's very important. This segment get inhibited by the loop diuretic like furosemide. Then the water will pass here, then it will reach to the collecting duct, and the collecting duct, the water usually excreted unless you have antidiuretic hormone in place. So if there is antidiuretic hormone will work, later on the aquaporin 2 channel will open. Under the effect of increased medullary osmolarity, water will be reabsorbed and pulled into the interstitium. So again, so if you have, this is the collecting duct, this is the arginine vasopressin receptor. So if you have antidiuretic hormone or arginine vasopressin, whatever the stimuli, osmotic stimuli or decreased intravascular volume depletion, it will bind to the receptor, it will stimulate cyclic AMP, and we have a water channel. We call it aquaporin channel. The aquaporin channel is inside the tubular cell. But once get activated, it will move from inside the cell to the wall here. It make a channel so the water will get absorbed. And you can see it here very clear. This is from earlier animal study. So this is the tubular cell. This is the luminal cell. So here is the urine here. So you see the aquaporin is inside. And once get stimulated, so it is inside. Once it get stimulated, it will move from inside to the luminal cell. So here, before giving these rats antidiuretic hormone, it was inside the cell, as you can see here with the arrows, but after get stimulated, it will move from here to the luminal cell. And it was measured. This is just, labeling density of the apical plasma membrane. You can see that the aquaporin in black, after giving the arginine vasopressin, it increased. And as I told you, the half-life is very short. So after a period of time, it was measured, it was reduced. And when they measure the osmotic water permeability, also is very clear that antidiuretic hormone is here. And once antidiuretic hormone given, you can see that the water permeability, osmotic permeability also increase. This is the most important slide about the pathophysiology of hyponatremia. If you understand this one, you will understand how we treat various forms of hyponatremia. The usual normal serum osmolarity around between 285 to 295. Beyond this one, the third osmotic threshold will get stimulated and the patient will start to seek free water. So if you exceed the 295, what will happen? You can see that the arginine vasopressin will get secreted here. So if it gets secreted to higher level, so the kidney will try to preserve water, so it will concentrate water. So you can see with the maximum arginine vasopressin, the urine osmolarity, it go to its maximum concentration ability, that is around 1,200 millismol. So what will happen if somebody drink huge amount of water and reduce the osmolarity? So if you reduce the osmolarity, so the kidney will try to get rid of all this excess water. So what will happen? So the antidiuretic hormone will shut down. And the urine osmolarity, it will go to the lowest concentration ability, that is around 50 millismol. From various animal studies, so there is variation in the secretion of the antidiuretic hormone. You can see like type A, this is the pattern that we see in patients with antidiuretic hormone. When you see with this shaded area, so this shaded area, this is when the serum osmolarity, this is the normal between around 280 to 290. So when you see the curve is going up, so this is the usual threshold for stimulation of antidiuretic hormone. You can see in this dotted line. So when the serum osmolarity increase to above 290, the antidiuretic hormone, it should go. That is a normal condition. If it is like type A, that is not related to increase in the serum osmolarity, this is what we see it in patients with antidiuretic hormone. We have type B. Type B, what we call it elevated basal secretion, despite normal regulation by osmolarity. We don't know the significance of this one. Type C, we call it reset osmostat. It is a benign condition. We see it in elderly patients. Type D, when the antidiuretic hormone, whatever serum osmolarity, it is undetectable. And this is the condition that we call it nephrogenic syndrome of inappropriate diuresis. We have type E. This is the normal relation between the serum osmolarity and AVB has reversed. And this is what they call it, the pyrostat reset. And we don't know the significance of this pyrostat reset. So the brain volume adaptation to hyponatremia, I think this is a very important topic to understand. So what happens if there is acute reduction of the serum sodium? So this is the extracellular fluid. And if the serum sodium in the extracellular fluid drop, so the osmolarity here is much lower than the osmolarity inside the brain cells. So if the osmolarity inside the brain cell is much higher, so it will pull the water. So water will move from the extracellular fluid into the intracellular fluid. So brain edema will develop. So as an adaptive mechanism, what happened? So something should move from inside the brain cell to outside to increase the osmolarity of the extracellular fluid. So within a few hours, the potassium and the sodium from inside the brain cell will move to the extracellular space, pulling the water out. So that's why in the chronic hyponatremia, you can see, so the serum sodium here, when it gets low, the water inside the brain cell, although it is high, but you can see that there is no brain edema, because after depletion of the potassium and the sodium, we have what we call it osmolyte. And we'll talk about the osmolyte later on. This osmolyte again will move outside the brain cell to make the intracranial pressure normal. That's why if we disturb this mechanism here by giving hypertonic solution that contain high amount of sodium, we will disturb this mechanism. So what will happen? So all the water here will move to the extracellular fluid, and this will cause central pontine demyelination. This is from the old studies that they look to the adaptation of the brain to the hyponatremia. This is when they measure the brain osmolyte, and you can see that the brain osmolyte with the lower serum sodium is much lower, and it is higher with higher serum sodium. So this is a protective mechanism. Example of these osmolyte: glutamine, glutamate, myoinositol, aspartate. When you look to the drawing on the right side, so here when they measure the increase in the brain water in relation to osmolyte. So when the brain loses the osmolyte, you can see that the increase is only 4% increase intracranial pressure. While if there is no osmolyte to be lost, you can see that there is increase in brain water that exceeds the 10%. Again, this one is just to review about the adaptation of the rapid change in the plasma sodium concentration. So on the right side, the rapid onset of hyponatremia, and here the rapid correction of the chronic hyponatremia. There is rapid decrease in the plasma sodium concentration, and this will lead to cerebral edema, and this will lead to herniation and the death of the patient. When it comes to rapid onset of hypernatremia, that is the opposite, or rapid correction of chronic hyponatremia. So there is a rapid increase in the plasma sodium concentration. So you can see here that the water inside the brain will be pulled out, and intracellular dehydration occur, and osmotic demyelination occur. Talking about symptoms of hyponatremia, you can see that the symptom of hyponatremia, it correlates with the degree of the drop of the serum sodium. It could be asymptomatic, nausea, vomiting, confusion, fatigue, and it can progress to seizure, coma, and even respiratory arrest. We'll go now to diagnostic approach to patient with hyponatremia. This is the classical algorithm for a classification of hyponatremia. So when you have patient with serum sodium less than 135, the first thing you will do, first of all, you will read the serum sodium, you will make sure that it is a true reading. You will measure the plasma osmolarity. And based on it, you will classify the patient into 3 groups. One group with hypertonic hyponatremia or isotonic hyponatremia if the serum osmolarity is normal. Or if the serum osmolarity is low, less than 280, we call it hypotonic hyponatremia, and this is the true hyponatremia. So you can see the rest of our talk will be about the true hyponatremia, that is the hypotonic hyponatremia. Once you diagnose the patient with hypotonic hyponatremia, you have to measure the urine osmolarity. If the urine osmolarity is less than 100, this is most likely related to excess water intake. And the condition that is related to excess water intake, like primary polydipsia, somebody who is drinking significant amount of free water, especially schizophrenic patient, low solute intake, and beer butomonia, that I will talk about it later on. But most of our talk today about patients with a true hyponatremia and urine osmolarity of more than 100. If it is a true hyponatremia with urine osmolarity more than 100, we assess the volume of the patient. So if the patient is hypovolemic, we measure the urine sodium. If the urine sodium on the left side more than 20 ml, so most likely related to the renal solute loss, and the typical scenario is cerebral salt wasting, or what we call it for the time being, renal salt wasting. I will not talk about it, but I am happy to receive any question about it in the question and answer session. If the urine sodium less than 10, so most likely extrarenal solute loss, like patient who is losing from the GI tract. If the patient is hypervolemic, if the urine sodium less than 20, we are talking about edematous disorder like heart failure, cirrhosis, nephrotic syndrome. If the urine sodium is more than 20 and the patient is euvolemic, we are talking about SIADH, we are talking about reset osmostat and potassium depletion, especially for patients receiving diuretic, and I will touch about the potassium depletion as a cause of hyponatremia. Again, you have to address hypothyroid, you have to address adrenal insufficiency. What is pseudo hyponatremia? I think everybody heard about pseudo hyponatremia. So when we take a blood sample from the patient and you put it in a test tube, so we have the cellular element and we have the plasma water. The plasma water is around 93%, and we have around 7% protein and lipid. So the lab, when we get the result, so it reports the serum sodium on the plasma water in this white area. So the lab will report the sodium in this area. But here the water in the plasma almost equivalent to the plasma volume because the amount of protein and lipid is almost negligible. But what the lab measure actually is the sodium in the plasma volume here. But since the plasma volume is almost equivalent to the plasma water, so there is no difference between the reported serum sodium result. Let us see the condition of pseudo hyponatremia. And the condition of pseudo hyponatremia when we have high lipid or high protein. It is in yellow here. So there is reduction in the plasma water, but the plasma volume is still the same, because the plasma volume is the plasma water زائد the protein and the lipid element. So the lab will report the sodium in the plasma water, but actually it measures the sodium in the plasma volume. And here it's very clear that the plasma volume is almost, double the plasma water. That's why we will have the low serum sodium measurement. So this one only if the sodium measured by what we call it a flame photometry. But it is not happening when patient having his serum sodium measured by ion-specific electrode. Just a few lines about pseudo hyponatremia, since we have a lot of medical students joining us today. So it occurs in case of hyperlipidemia or hyperproteinemia. The osmolarity here is normal. If you measure the serum anion gap is normal, there is no treatment needed because it is factitious. And again, it can be overcome by using ion-specific electrode. By the way, if you are using the ABG machine, so the ABG machine will give you the accurate result because they are using the ion-specific electrode. What about hypertonic hyponatremia? Hypertonic hyponatremia, when you have hyperosmolar solute in the extracellular fluid. So what will happen? So the osmolarity in the extracellular fluid will be higher than the osmolarity in the intracellular fluid. So water will move from the intracellular space to extracellular space, expanding the extracellular fluid, so leading to dilutional hyponatremia. Although the total body water here is normal, but the ratio between the intracellular and extracellular fluid water is disturbed. So it's dilutional hyponatremia. This is an example of hypertonic hyponatremia. The commonest one is hyperglycemia. And a very important statement to be remembered that the sodium will decrease by 1.6 milligram. That was approved from many studies for each 100 milligram increase of glucose above 200 milligram per deciliter. Also, mannitol will give the same condition. In this condition, the osmolar gap, that is the difference between the measured osmolarity and the calculated osmolarity, will be more than 15. IV immunoglobulin, especially if they are using saccharose or maltose as vehicle, also can give us hypertonic hyponatremia. What about glycine and sorbitol induced hyponatremia? This one is very important for surgeons, especially for urologists and for obstetrician. So glycine used for irrigation, especially after transurethral resection of the prostate or many ovarian resection procedures. So glycine will stay in the extracellular fluid. See, it's not absorbed. It will stay in the extracellular fluid. It will expand the extracellular fluid. So it will not pull the water because the osmolarity of glycine is normal. It will just expand the extracellular fluid. So here, when you measure the total body fluid or total body water, you will find it's increased. That's why when you measure the weight of this patient before the procedure and after the procedure, you can see that there is an incremental increase in the body weight, and this is related to reabsorption of glycine or sorbitol. Few words about sorbitol or glycine-induced hyponatremia. Glycine is isotonic solution used as irrigant in TURP or intrauterine surgery. Large volume absorbed from the abdominal cavity that expand the extracellular fluid, causing dilutional hyponatremia. It gets metabolized with time to urea. Usually there is no treatment needed. It treats if symptomatic. So what we do usually, we wait for spontaneous diuresis. So when the patient starts to diurese, so the water will get excreted and the serum sodium will start to normalize. If the patient starts to have severe symptom, you can give the patient diuretic. So he will excrete free water and the serum sodium will get normalized. Just for the information, new bipolar electrode for the time being that's used for cautery allow the use of normal saline as irrigant. One important topic all the time addressed when we talk about hyponatremia, why hyponatremia is rare if we are using loop diuretic, while it is common for patient who is using thiazide diuretic for treatment of hypertension or treatment of heart failure. Again, you remember this dilution segment. dilution segment when we have the reabsorption of sodium chloride without water. This is the area that get blocked with the loop diuretic. So what happened here? If you block this one, so there is no much increase in the medullary sodium here. So if you go here to the drawing here, so this is the osmotic gradient. So the osmotic gradient, normal person, it increases from 300 to 1,200 because of increased reabsorption of sodium into the medulla here. And this will pull the water from the collecting duct. So patient will reabsorb. But you can see here that the osmotic gradient gets reduced because the osmolarity in the interstitium, it get only reach about 800. So the difference here is around 500. Why the difference here is around 900? So again, so the hyponatremia, it is related to excess water. That means reabsorption of water. That's why in the loop diuretic, because there is no much increase in water reabsorption here, that related to impaired osmotic gradient, so patient rarely develop hyponatremia. Let's go when we are using thiazide diuretic. You can see that, you know, this area in the thick ascending loop of Henle, it is normal. So through the sodium potassium to chloride channel, sodium and chloride get absorbed. Look here, that the osmolarity in the interstitium is almost normal and similar to normal healthy patient who is not taking any diuretic. Thiazide diuretic work in the distal tubule. It will block the absorption of sodium from the distal tubule, but the absorption of sodium here is very minimal. But you can see there is no increase. There is increase here of the water reabsorption. So the increase of water reabsorption here, that led to the hyponatremia development in patient with thiazide. That is opposite to patient who was taking loop diuretic. So the story related to the osmolarity and the osmotic gradient in the medulla. Few words about thiazide-induced hyponatremia. It is common, is almost in 13% of patients taking diuretic. It implicates to almost 26% of all hyponatremia patients. It is common in hospitalized hypertensive patients. Risk factor, elderly, female, low body weight, and it increase incidence during the hot and warm seasons. It is more common with chlorothalidone. We don't have chlorothalidone in Saudi Arabia, than hydrochlorothiazide. And in hydrochlorothiazide, it's more common than indapamide. That is the Natrelix. So how we treat this patient? So I'll talk about general strategy for treatment of hyponatremia. When you face a patient with hyponatremia, the first question you have to ask yourself, is it symptomatic or asymptomatic? The second question, is it acute or chronic hyponatremia? And the definition of acute versus chronic is less than 48 hours considered acute, more than 48 hours considered a chronic. And I will tell you what is the significance of knowing acute versus a chronic. Any patient, by the way, comes to the emergency room considered as a chronic because we don't know the baseline serum sodium. So the management strategy based on the risk of treating hyponatremia to the risk of overcorrection and the development of central pontine myelinosis. When you look to acute hyponatremia, when there is marked brain edema and symptoms, so the risk of hyponatremia and death because of herniation overcome the risk of correction. So that's why in the acute hyponatremia, we give the hypertonic saline. In a chronic hyponatremia, when there is some brain edema, there is partial brain volume regulation. So there is equivalent risk of the hyponatremia, and the same thing, there is equivalent risk of correction. While for somebody with a chronic asymptomatic hyponatremia, when there is minimal brain edema, complete brain volume regulation happened here. So the risk of hyponatremia, you know, is less than the risk of correction. So that's why here, you know, the correction should be very slow because we don't want to disturb the autoregulatory function of the brain. Classification of hyponatremia based on the symptoms. We have moderately severe, patient with nausea without vomiting, confusion, headache. Severe when there is vomiting, when there is arrest, when there is seizure, or there is coma. And here, in this patient, whatever they have, acute or chronic, that we have to act promptly and we have to give the hypertonic saline. Pitfalls in the treatment. Osmotic demyelination syndrome occur with rapid correction with the chronic more than acute hyponatremia. The target increase in serum sodium concentration, total of 10 millimole per liter during the first 24 hours, or 18 within 48 hours. That means 10 in the first 24 hours and 8 in the second 24 hours, until the serum sodium concentration reach 130. For higher risk group that I will talk about for osmotic demyelination syndrome should have lower and slower rate of correction, 4 to 8 per hour. This is from animal study. This is very old study for the time being. This is for rats. When induced to have hyponatremia more than 48 hours. When the open bars here, you know, this is the surviving animal, the percentage of surviving animal. So the open bar here, you can see when there is a slow correction, you can see by 5 days, almost all of them survive. When you can see here in the black square in the middle, when there is rapid collection with hypertonic saline, you can see almost 40% of these animals died by 5 days. And if there is water diuresis, you can see more than 60% of these animals died. And from this animal study confirmed that, you know, rapid correction of hyponatremia is dangerous and can lead even to death. While in acute hyponatremia for the same animal, whatever giving a slow correction or rapid correction, you can see almost all the animal survive from this study. And this is a recent study when they look to a cohort of patients with chronic hyponatremia and severe hyponatremia. Their serum sodium is less than 105. And good number of them, they have neurological symptoms. That usually occurred more than 12 milliequivalent in a 24 hour or 18. Just try to concentrate here. So this red dots, if the patient having a neurological complication, and this open triangle, if there is no complication, you can see that people who develop a neurological symptom, all of them, they have overcorrection. You can see more than almost 10 within 24 hours in the x-axis. And this is in the y-axis. This is more than 48 hours and more than 18 in 48 hours. And that's why the guidelines suggest not to overcorrect by 10 within the first 24 hours and 18 within 48 hours. Again, when they look to patients who develop central pontine myelinosis, either diagnosed by autopsy or by MRI, again, you can see they lie in this area. So almost all of them, they have their serum sodium with a 24-hour overcorrected more than 10 or more than 18 within 48 hours. This is a recent study also, almost 2 years ago, it was published. They look for the question of this study, what are the risk factors for rapid correction and osmotic demyelination in patients with severe hyponatremia with serum sodium less than 120? The cohort almost 1,500 patients. All of them, they have serum sodium less than 120. The result, rapid correction of sodium more than 8, they choose it for 24 hours, occur in almost 40% of the patients. So 606 of patients, they have rapid correction. What are the risk factors for rapid correction? Younger patient, female, psychiatric patient, patient with lower initial serum sodium, and patient with lower initial urine sodium. And they have 8 patients from this study developed osmotic demyelination syndrome. Almost 7 of them, they have a rapid correction of sodium. 5 of them, they have beer butomonia, we'll talk about it. And 5 of them, they have hypokalemia. Conclusion from this study, among patients present with severe hyponatremia, rapid correction occur in 40%, nearly all patients with incident osmotic demyelination having documented episode of rapid correction. Few words about osmotic demyelination syndrome. It was described in 1959 at that time, not in hyponatremic patient, but was in malnourished alcoholic patient with hypokalemia at that time. In 1976 was recognized as complication of rapid correction of hyponatremia. Risk factor, rapid correction of hyponatremia, patient with hypoxemia, especially intubated patients, severe liver disease, alcoholism, cancer, severe burn, malnutrition, and hypokalemia. Osmotic demyelination syndrome has biphasic pattern. So when the serum sodium overcorrected, initially you will find there is resolution of the symptoms. But later on, especially from the 2nd and 3rd week, you will find development of a new neurological symptom. And these symptoms in form of dysarthria, dysphagia, paraparesis, quadriparesis, behavioral disturbance, movement disorder, seizure, lethargy, confusion, coma, and death. So initially there is improvement, and later on, after 2 weeks, another symptoms, it will occur, and this can lead to devastating event, including death. MRI is the best diagnostic tool. Unfortunately, no proven therapy. The mortality rate by 2 weeks, almost 50%, and 90% at 6 months. Some people, they use steroids, some people, they use hypertonic saline, some people, they use plasmapheresis, some people, they use like the osmolite myoinositol, but again, there is no proven evidence-based treatment for central pontine myelinosis. What are the treatment options that are available? This is for chronic asymptomatic hyponatremia, fluid restriction. It is available. The problem with the fluid restriction, that non-compliance. We have lithium and democlocycline. This will induce nephrogenic diabetes insipidus and will lead to water diuresis. But again, this is a drug not without side effect. If you take lithium, for example, it can cause polyuria, it can cause a neurotoxicity, and can cause also nephrotoxicity. Democlocycline also, it can cause a neurotoxicity, photosensitivity, nephrotoxicity. And we have the Vaptan, that is the V2 receptor antagonist. The commonest one available is tolvaptan. The dose is between 15, you can increase to 30 and 60, and it can address the underlying mechanism, especially for patients with SIADH. We'll talk about the available data. You can use furosemide to increase water diuresis, and you can use urea, and we'll talk about the use of urea. So what are the guidelines for the treatment? We have 2 guidelines. We have the American guidelines, and we have the European guidelines. Between them, 7 years. So for acute asymptomatic hyponatremia, the American guideline said severe symptom, and severe symptom, that means seizure, coma, or respiratory arrest. Give bolus of 3% around 100 cc of normal of 3% saline over 10 minutes. You can repeat it up to 3 times. The European guideline, they increase from 150, from 100 to 150, and you can give it also up to 3 times. For moderate, you can give an infusion in the American guideline, but in the European guideline, again, you give boluses. What you can see here, there is no use or recommendation to use any formula for infusion. And with the new guideline, only we will go with boluses. And I will tell you why we will go with boluses. Not only because it is very easy to remember, you don't need for calculation, but also the expected diuresis is more predicted when you are using boluses. If you have patient with SIADH, I will concentrate for the time being in the European guideline because I think all of us, we are moving to use the European guideline. First line, use a fluid restriction. You can use urea. Urea was not addressed in the US guideline, but now it is, so it was addressed, but now again, it was added to the new guideline. Loop diuretic, you can use oral sodium chloride tablet. It was not in the previous guideline. There is no recommendation with the use of Vaptan, although it was recommended in 2007. Keep in mind, in the 2007, at that time, tolvaptan is not available, but it was recommended based on the pathogenesis of hyponatremia and SIADH. Here, it was not recommended because of the price. For hypovolemic, you give normal saline. Hypervolemic, fluid restriction as a first line. You can use Vaptan in the old guideline. The new guideline recommend against the use of Vaptan. Correction rate, I think both of them, they share the same correction rate. So it's between 4 to 10 within 24 hours. How you manage overcorrection? With the new guideline, they said, consult the expert to discuss infusion containing D5 water here, or use with or without the use of desmopressin or DDAVP. And I think I will talk about this one. So for acute, we use the hypertonic boluses. So for chronic, especially we are talking about the SIADH, again, I will summarize it. So fluid restriction, you can use urea with or without diuretic or sodium tablet. And if the patient having severe symptom, you will use the 3% saline as boluses. One important point to judge you regarding your treatment, fluid restriction alone is unlikely to work if the urine osmolarity is more than 500. That's why it's very important to classify your patient based on the initial available labs. Sometimes for high risk for overcorrection, what we do, we give a prophylactic desmopressin. That is Arginine Vasopressin. And you can see from this study, so this patient who presented with serum sodium of 95, you can see with the 3% saline, you can see that the actual one that was by measured, it was in green. When desmopressin was given here in between as boluses, and the patient continued on a 3% saline, you can see that almost the actual reading equivalent to the ideal. So for high risk, you can give the 3% saline. If you are afraid from overcorrection, you give arginine desmopressin or vasopressin as a prophylactic. It's very important to measure the serum sodium every 2 hours by using the ABG machine. And the most important is to measure the urine output, because what predicts the overcorrection is the urine output. It's not the amount of the sodium in the 3%. So the 3% will shut down the antidiuretic hormone, but the free water that gets excreted will lead to an increase of the serum sodium. So if you have a patient that within a few hours, he developed overcorrection, we said that the target correction, let us say 10 millimole within 24 hours, but you have after 1 hour or 2 hours, after 3%, your patient overcorrected. Plasma volume, you have to relower the serum sodium. Best accomplished by co-administration of desmopressin, that is DDAVP, and D5 water. The dose of DDAVP is 2 to 4 microgram. You can give it IV every 6 to 8 hours. The dose of D5 water is around 3 cc per kg per hour. And this will be enough to reduce the plasma sodium by almost 1 milliequivalent per hour. That was estimation from a previous study. Once the target sodium achieved, consider stopping the D5 water. Hypertonic saline, it can be added after 48 hours later on if you don't achieve your target. This is one of the cases that I encountered 2 weeks ago. So 65 years old patient, he's hypertensive, he's having CKD, So his data on the blue box, creatinine around 130 to 150. Just to cut it short, he's using indapamide, thiazide diuretic. He presented with 4 days of confusion and a questionable seizure as per his family. But his son, he said that also he was drinking plenty of water. That was during, I think, the first week of Ramadan. His blood pressure was normal. He was euvolemic at that time. His initial sodium was 96 by the ABG because by the lab it was undetectable. Potassium is 3.6. Serum osmolarity is 212. And urine osmolarity is around 200. And urine sodium is 28. You can see that over 10 days, this is every day, you can see that we increase his serum sodium very smoothly from 96 to 106 to 112, 115, 121, 129, again 129, 130, 134. I will tell you what we did. So the most important is the first 24-hour treatment. So when the patient arrived to the emergency room with serum sodium of 96, so he was given by our ER colleague 3% saline. So we saw him at that time, almost sometime here. So we don't have the repeated serum sodium. Unfortunately, at that time, there is no measurement of his urine output. So we asked to put a Foley catheter. And we said, we will replace his potassium, and I will tell you about the potassium. We'll give him some potassium, although his potassium in the lower side. And he said, okay, we'll finish our round and we'll come back to him after 2 hours when the next reading is coming. So we came after 2 hours, his serum sodium increased to 101. But for the last 2 hours, his urine output increased. Almost he put 600 cc of urine within 2 hours. So what we did here, so we gave him 2 micrograms of DDAVP. The next reading, 107. Next reading, plateaued 107. And by the end of 24 hours, it was 106. Look to the urine output. That's why I said the hourly urine output is the most important, between 50 to 100. And you can see in the second day, it increased by the end of the second day from 106 to 111. So delta sodium within 24 hours, around 10. Delta, or the change in the serum sodium within the 48 hours, it was only 7. So if you face such patient, you can give prophylactically DDAVP, and every time if he put urine output more than 200 cc per hour, give him another dose of DDAVP, and you will have very smooth correction, even if the patient is high risk. Why we have to correct hypokalemia, and why hypokalemia is a risk factor for hyponatremia? Potassium is the most common cation inside our cells, while sodium is the most common cation in the extracellular fluid. So when we have hypokalemia, so that means the measured serum sodium in the extracellular fluid is low, so the body will try to correct for this. So what will happen? So potassium will move from inside the cell to outside the cells. Potassium is positively charged, so the sodium will go inside the cell. That's why patients with hypokalemia will develop hyponatremia. So one of the mechanisms is charge exchange. So the sodium will move inside the cells. But again, with the movement of potassium from inside to outside, there is movement of water. So this is what happens. So potassium will move, water will follow the potassium. So the extracellular fluid will expand, and in the same time, sodium will get in. That's why any patient with hypokalemia is very important, to correct the serum potassium if their serum sodium is low. So correct potassium, put your patient in fluid restriction, and then follow the guideline. Why we are not using a formula? We have many formulas. This is the most common formula. You will find it in all calculator. They call it, Argos Medius formula. This will tell you the change in the serum sodium if you give 1 liter of whatever infusate. Like if you are giving a 3% sodium chloride, so what is expected, a 1 liter will raise the serum sodium. And I will not talk about it, and I have, just one way of the calculation, but because of the time, so I will skip it, and I will go why the formulas is not put into the guideline. So formula was removed from the guideline because of this. This paper was published 2007. Among patients with serum sodium less than 120, the observed increase in the sodium exceed the raise predicted by the formula by 74.2%. So 74% of the patient, the serum sodium will be exceeded the target. When you look to the overcorrection, is 2.4 times the predicted. And the water diuresis, occurred in 40% of the patient. So after this study, the new guideline, they remove, the formula. It's not only because it is complicated, but again, it is not that accurate. So that's why we are not talking about formula. Very important to determine the urine output, and very important also to understand the concept of urine output. So the urine output, or the amount of urine that we put, it is a ratio between the urine solute excretion and the urine osmolarity. So what is the urine solute excretion? It depends to the number of solute that we get from our food. It was estimated to be around weight multiplied by 10. So if you have somebody, his weight is 70 kg, so the normal solute excretion will be around 700. So 70 multiplied by 10, around 700. So if this patient who is having normal kidney function, urine solute excretion is 700. If he drink up to 14 liters, because he will reduce the urine osmolarity, because he will shut off the antidiuretic hormone, he can excrete all these 14 liters of excess water to maintain the serum sodium. But this one will not happen if the patient having low urine solute excretion. This is again, just to tell you that the free water clearance, it depends on the number of solute excretion. Down here, if the solute excretion is around 300, and the upper violent curve, this is if the solute excretion more than 900. And you can see that the free water, even at lower osmolarity, is much higher if the patient having high solute excretion. And this is very important because it has some therapeutic implication. We will talk about urea. Why when we give normal saline, SIDH is not corrected? Just this very demonstrative example. If you give 1 liter of normal saline, that contain around 300 milliosmoles in 1 liter. So the urine output, let's assume that the patient urine osmolarity is 400. Most of the patients with SIDH urine osmolarity around 400 to 500. So 300 divided by 400, this will give us a urine output of 700 cc. So you are giving the patient 1 liter, and this 1 liter produce only 700 cc. So you put 1 liter, produce 700 cc, and the patient will gain 230. That's why the hyponatremia will not correct it. Let us see if you give 3% saline. Let us say that you decide to give 3% saline. The 1 liter of 3% saline, it contains 900 milliosmol. So the expected urine output after 1 liter, so 900 for the same urine osmolarity, 400, it will give us 2.25 liters. So you give the patient 1 liter and the patient to produce 2.25 liters. So there is a fluid deficit by 1.25 liters. That's why the 3% saline worked here. We'll talk about the poor solute intake and beer bottomania. The normal urinary electrolyte, we have the sodium, potassium is around 200. We have some anion that accompany the potassium and the sodium around 200. We have urea, 100 from the catabolism, from food, and from our diet we get around 50. So the total is 400 is 500. So the total solute that we have, total is 900. Clinical setting with low solute that we have this one, alcoholism, because low of this, and I will talk about it, so low sodium and potassium. Anorexia, because poor intake here. So they have lower normal urinary urea. So beer bottomania, I will give you this example to understand the beer bottomania. So for people who are binging in the weekend and drinking significant amount of beer. So let us assume that this person, he consumed 5 liters of beer. The beer contain only 2 millimole of sodium per liter and 10 millimole of potassium per liter. So it is very poor in solute. He took 5 liters. So the sodium in this 5 liter around 10 millimole, the potassium around 50. Let us say that he excretes around 90 millimole of urea. So the total solute is around 150. Let us assume that he's having normal kidney function and he can reduce the urine osmolarity up to 50. So the urine volume, number of solute, that is 150. You divide it by the urine osmolarity is 50, is a 3 liter. So what happened? He drank 5 liter and he excrete 3 liter. That there are 2 liter of hypotonic fluid return. That's why hyponatremia developed. Treatment, high protein diet, just to increase the number of solute. You can use salt tablet, you can use urea in addition to fluid restriction for this patient. So if the same person, if you give 30 grams of urea, this 30 grams of urea, it will give around 500 milliosmol. So I made the urine osmolarity as around 500. This is for the same person with SIADH. So if you give 30 grams of urea, so this will give 500 milliosmol. And if the urine osmolarity is around 500, so the patient, just by taking a sachet of urea, he will put around 1 liter of urine. So he did not take any water. He did not take any fluid, but he put around 1 liter. That's why urea is very excellent medication for patients with a true hyponatremia, especially SIADH. So how urea, this is, I think I will skip this one for the time being. So this is just to give you example of urea. So if you give 30 grams of urea, that contain 500 milliosmoles, this is the brain cells. So it will increase the plasma osmolarity. So water will move from the brain cells into the extracellular fluid space. And then if you look down, so the urine osmolarity, because of the solute increase, so the excess water will get excreted and the plasma sodium will get improved. So the initial condition or the first few hours, you can see serum sodium is almost the same, but the plasma osmolarity increase. While when you look after a few hours, you can see that the serum sodium will start to improve dramatically, while there is a little increase in the plasma osmolarity because of the excretion of urea in the urine. And this is just one study that look for the use of urea in 58 patients. You can see sodium increase from 124 to 131. Only one patient did not tolerate urea, mainly because of the smell. There is no overcorrection if you are using urea. Sometimes we use a formula, we call it electrolyte-free water clearance to judge if your fluid restriction is working or is not working. And this is the formula. V is the urine volume, 1 minus urine sodium minus urine potassium divided by the serum sodium. Just I will give one example, hopefully I will run very quick. So this patient is 65 years old with SIADH, serum sodium 121, urine output around 900 ml, urine osmolarity is 600, solute excretion based on his body weight is around 600 millimole, urine sodium around 100, urine potassium 66. At that time, he was put on a fluid restriction. So let us see what happened with 500 cc fluid restriction. If you apply the formula, V is the urine. So the urine volume, he was putting around 900. 1 minus urine sodium around 100, urine potassium around 66, serum sodium 120. So the result is 333 N minus. What does mean N minus? That means I put the patient in a fluid restriction, but the patient return is 333. That's why fluid restriction is not working. And I said earlier that especially SIADH, when the urine osmolarity more than 500, they are less likely to respond to fluid restriction alone. Let us see what happens if you increase the solute excretion. If you double it here, the urine output will increase to 1,800. And if you calculate with the formula, just to tell you that the electrolyte of free water excretion, just by increasing the number of solute by whatever urea or sodium chloride tablet, it is 558. So he would excrete 558. Although the patient at that time, he was returning around 300 plus. One important aspect that we face for patients with acute kidney injury or patients who have dialysis. These patients, most of the time, they are anuric. So for this patient, it's very important to know that our dialysate sodium, we have ranging between 130 to 140. So if they come with severe hyponatremia and you connect them to the machine, almost they will, especially if they have severe hyponatremia, they will overcorrect. So what we do, we can put distilled water into the 5-liter bag and we dialyze them by using the CRRT. So patients with severe hyponatremia who have acute kidney injury or patient with end-stage renal disease, we don't use, in most of the cases, conventional hemodialysis machine. We use the CRRT machine and we install distilled water to reduce the final dialysate sodium. We can reduce the dialysate sodium up to 112. So if you add to the 5-liter bag 1.25 liter of distilled water, you can reach dialysate sodium of around 112 to prevent the overcorrection. What about vaptans? I showed you this one. So here, this is the vasopressin. This is the V2 receptor. So this is the vasopressin. So the vasopressin, when it binds to the receptor, through the cyclic A and B, it will move the water channel here from inside the tubular cell to the luminal cell. It will open gate so the water will get in. So the vaptans, like tolvaptan, it will block the receptor here. So there is no water channel here to allow the water to be reabsorbed in the collecting duct. I will go with the most important study about the use of tolvaptan. This is published in New England in 2006, and based on this one, they get approval for FDA. It's called SALT-1, and SALT-2 is the same study, just one in USA and the second one in Europe. It is randomized controlled trial. They randomize patients to receive either placebo or titrated dose of tolvaptan from 15 to 60. And the primary endpoint was the average daily area under the curve serum sodium concentration. Just to tell you, they have almost similar distribution of patients. This is when you see the change in the average daily sodium concentration, you can see it's much better in tolvaptan. This is for all group than the placebo. This is for marked hyponatremia. This is for mild hyponatremia. This is for SALT-1, and this is for SALT-2. This is on day 4. The same trend, you can see it on day 30. So it is very clear that vasopressin antagonist, it will raise the serum sodium in patients with hyponatremia. Very important in the inclusion criteria, they are euvolemic or hypervolemic. They exclude any patient with hypovolemia. Again, you can see tolvaptan, there is a smooth increase of the serum sodium in SALT-1 and SALT-2. But here is the problem, by 30 days. When tolvaptan stopped here, unfortunately, the serum sodium went back to normal. The same thing for SALT-2 study. That's why it was removed from the guideline. There is some extension of this study, they call saltwater study. So they look for the patient, a group of patients who continue the Vaptan for almost 214 days. This is, again, this is the Vaptan up to 30 days. If you remember, when they stopped, serum sodium went back to normal. These group who have mainly SIADH, congestive heart failure, and liver cirrhosis. Salt water, so the group who continue, while they are taking the Vaptan, their serum sodium almost normal. But again, by 200 days, when they stopped, their serum sodium went down, unfortunately, to the baseline. Side effect, thirst, fatigue, dry mouth, polydipsia, hypotension, polyuria. This is the main side effect. So again, just to remind you about the recommendation regarding the use of Vaptan. So in the new European guideline for the hypovolemic hyponatremia, it's not recommended. For euvolemic, it's not recommended. For hypervolemic, it's not recommended. Why? It was recommended in the American guideline, but the American guideline, it was not evidence-based. It was expert opinion. So again, for the time being, if you are following the American guideline, you can use the Vaptan in hypervolemic or euvolemic hyponatremia. But if you are following the European guideline, there is no rule for Vaptan. Okay, one slide about Vaptan. If they are approved for treatment of hypervolemic and euvolemic hyponatremia in 2009, no data, unfortunately, that it reduced the mortality. Overcorrection is rare. No single case of osmotic demyelination syndrome. So with Vaptan, there is, so if somebody, document osmotic demyelination syndrome with Vaptan, it will be a case report and he can publish it. I address the side effect like thirst, dizziness, polyuria, postural hypotension. There is a black box warning by the FDA about hepatic toxicity, but there is no case of liver failure, and liver enzyme went back to normal when it was stopped. Serum sodium will go back to the baseline, unfortunately, once Vaptan stopped. The problem is the cost. Concentrate with me with the cost. One tablet from Otsuka, from the manufacturing company, either 15 or 30 milligram, it will cost around $177. One tablet. So if the patient using 2 tablets or 60 milligram, so the patient almost using a 300 US dollar, that is around 1,000 Riyal for a treatment per day. That means if you will give a patient with SIADH 12 Vaptan for 1 month, it will cost around 30,000 Saudi Riyal. So hopefully we will get the Vaptan in Saudi Arabia with lower price, and we will have, inshallah, our local data. One interesting study that was just published recently, they look about SGL2 receptor. They look for empagliflozin. This is SGL2 receptor. It is used for type 2 diabetes for the time being. And the idea of it, the SGL2, it can cause glucoseuria. So glucoseuria, when the glucose will go into the lumen, so it will cause osmotic diuresis. So one group of investigator, they tried to use empagliflozin in healthy volunteer, and they found that their water output increased dramatically because of osmotic diuresis, but it did not affect the serum sodium. So what they did, so again, just to tell you here that SGL2, it works, the receptor, we have it in the proximal tubule. So if you block it, you will block the uptake of glucose, and at the same time, you will prevent also the uptake of sodium. So you can see that the glucose and the sodium will go and will get excreted. So the osmolality in the lumen here is high, so water diuresis will occur. So they did randomized control trial. This is from Switzerland. They look for 88 patients. All of them, they have SIADH. You can see here, this is day 0. This is day 4. You can see that the weight reduced by almost 3 kg, while in the placebo group, there is no change in the weight. By day 4, the serum sodium here increased to 134 smoothly, and here it increased to 133. Again, Here, the change in the plasma sodium, again, empagliflozin is much better than placebo. And here, just to tell you that, when they sub-classify the group, they found that patient with lower serum sodium, here, less than 125, and patient with lower serum osmolarity, they have better response to the empagliflozin. We don't recommend the empagliflozin for the time being, but it is a drug that to be considered, especially for somebody who is diabetic. I will conclude by a few slides about data from registries. When you look to the registries now, we have hyponatremia registry in cancer patient. We have hyponatremia registry in liver cirrhosis. We have thiazide-associated hyponatremia registry. We have hyponatremia registry in patients with heart failure. Unfortunately, we don't have a local registry. And I brought this one because this is an area that will stimulate us to think about collaboration and to get our own registry and our own data. I will come with this study because it is the largest study for the time being, and almost the same author who get involved. This is the first registry data they have, and then they get involved themselves in the different registry I showed you. They have around 3,000 patients, 1,500 with SIADH, around 760 with congestive heart failure, and the rest with liver cirrhosis. The majority of them, they are white. Median initial sodium around 125, almost in all of them. Almost all of them, they have normal kidney function. A previous hyponatremia, it was on 30% of patients. Care of hyponatremia, you can see it was cared by nephrologists, endocrinologists, cardiologists, hepatologists, oncologists, but the majority of them, more than 60%, by general internists. And hyponatremia specialist consultation was done in almost 1/3 of the patients. Okay. So first of all, they look for the workup for hyponatremia. What's the percentage of patients who get the complete workup done? So when they look to SIADH, around 1,500 patients, serum osmolarity was measured only in 66%, urine osmolarity only in 68%, urine sodium only in 63%, and the three of them combined only done in 47%. And very interesting that 11% of the patient, they have none of these tests done. Cortisol was measured in 33, TSH in 64, and when you combine the adrenal, thyroid, in addition to the urine osmolarity, serum osmolarity, and urine sodium, all of the five were made only in 20% of patients. So we have to improve our diagnostic workup because it has some implication when we measure our treatment effectiveness. So let us see the initial treatment from this registry. This is all patient here, upper left, 17%, untreated, fluid restriction, 35%, normal saline, 15%, 12-heptane, 5%, alone. Hypertonic saline in total only 2%. Again, when we look to SIADH, the commonest therapy used around 26%. For whatever reason, 23% of these patients with SIADH, they are given normal saline as initial treatment. 12-heptane was used in 5%. Hypertonic saline was used in 3%. Congestive heart failure, 23, untreated, fluid restriction in most of the patients. You can see that 44% fluid restriction, hypertonic saline in 2%, 12-heptane in 4%. Liver cirrhosis, again, 20% untreated, and fluid restriction is the commonest initial intervention in 48%. Again, this is the classification of the intervention with various levels of sodium. If you go to the lowest sodium level, fluid restriction in 30%, normal saline in 18%, hypertonic saline in 5%. When you go to the mild, you can see untreated, 25% untreated, fluid restriction in 38, normal saline 12, 1%, hypertonic saline only, and tolvaptan in 5%. You can see the response to the initial treatment. Median rate change per day for no treatment around 0.4. Even with this one, the overcorrection was occur in around 1%. Fluid restriction, median rate of change per day is around 1. For the first day, around 2. When you go to the hypertonic saline, again, you can see the median rate of change is around 3. But the problem that if you are using the 3% saline or tolvaptan, you can see here that 14% of patients given hypertonic saline, they have overcorrection within 24 or 48 hours. The same thing for tolvaptan group. Just to tell you that if you are using fluid restriction, I mentioned, especially for patients with very high initial urine osmolarity more than 500, the chance that the fluid restriction will work alone is around 40%. So around 44% fluid restriction alone worked. The rest fluid restriction did not work. If you see the second intervention was given, tolvaptan, success rate 50%, hypertonic saline success rate as secondary intervention around 60%, normal saline as secondary intervention around 44%. At discharge, this is very important. Serum sodium concentration under 135 in almost 2/3 of the patient, and less than 130 and less than 48. And I found almost in all the registry, so almost 2/3 of the patient, unfortunately, they were not discharged with the target sodium that is around 135. So what we learned from the registry, I will conclude with this slide. There is incomplete diagnostic workup for hyponatremia. So this one is very common. Fluid restriction is the most common initial therapy. Although only 44% of hyponatremic patients corrected with fluid restriction alone. And I said, especially for patients with very high urine osmolarity at initial presentation. 17% of hyponatremic patients did not receive any specific treatment. Hypertonic saline used in 2% of patients, and this is something good because at one stage, every single patient given a 3% saline, because now people, they start to become more conscious about osmotic demyelination syndrome. Tolvaptan from this study used only in 5% of patients. Overcorrection occurring around 8%, more common with the use of hypertonic saline or tolvaptan, and unfortunately, good number of patients discharged with serum sodium less than the target. By this, I will conclude my talk, and I am happy to receive a question. Thank you, everybody. Questions?
Thanks, Dr. Fadel, for this nice lecture. I think we have a lot of questions here in Q&A. I think it's available in your screenshot when you
so
your Q&A.
I can read one of them. So one question about why the Vaptan not recommended anymore by the European Union guideline. And I think it was driven by the price. If the price is much less, and I think you will find it later on when we have the generic form in the updated guideline, you will find it recommended. Especially, there is no single osmotic demyelination syndrome. Although they mentioned that because of price, because if you stop it, the serum sodium will go back to normal, and because of the FDA black box warning, they remove it from the guideline. But when you look to the pathophysiology, Vaptan at work, it will lead to smooth raise of the serum sodium, and I think that with the generic that will come with lower price, hopefully we will find a place for the Vaptan. I have another question. Drinking water lead to decreased serum sodium in the blood. We talk about, hyponatremia is a relation between the extracellular sodium and total body water. But if you have a normal kidney function and normal antidiuretic hormone and diluting loop, as I mentioned, so if you drink, let us say, around 10 liters of water, and you have normal kidney function, and you have normal diluting loop, so the antidiuretic hormone will shut down, and the urine osmolarity will go to the lowest, that is 50. And very easy, you know, within a 24-hour or 48-hour, you will excrete this 10 liter and your serum sodium will go back to normal. So the problem, if you have another disease that will keep the antidiuretic hormone high, mainly we are talking about medication, or you have chronic kidney disease, so you will not be able to excrete this extra water from the GFR. Another question, what type of diuretic do we use with glycine-induced hyponatremia? The most potent diuretic is furosemide, so we are using the furosemide or the loop diuretic, so it is the most effective and it will work. I'm trying to see more question. Do we need to calculate the sodium deficit from Khalid Al-Harbi? As I told you, for the time being, the new guideline, they don't recommend to go with the calculation of the sodium deficit. You can do the calculation. There are many formulas for the sodium deficit. There is also the Medius formula also to calculate how much sodium will be retained if you give like 3% saline. But I told you, all these formula, unfortunately, you know, 74% of the patient, you know, they will exceed their target. So it is not accurate formula. And if you give just boluses, especially we are talking about the severe hyponatremia and 3% saline, it is more predictable. If you give a bolus, you monitor the urine output and you monitor the serum sodium every 2 hours. You can measure it. This is up to you if you want to measure it for academic purpose. Your opinion regarding using hypertonic saline bolus, peripheral versus central. We don't use it in central line. We don't need to insert central line. This is different from the IV calcium. We know that the IV calcium, you cannot give it in the peripheral line, especially if you want to give it as infusion, because it can cause a thrombophlebitis if it is high. Whereas for the sodium, it is okay to give it. And usually we don't give it as a push. You can give it over 10 or 20 minutes. So all the patients, when they come to the emergency room or in the floor, we give it through peripheral line. So you don't need to go for invasive procedure like central line. Question regarding difference in treatment between adult and children. I don't think there is difference in the treatment between adult and children if you understand the pathophysiology. That's why understanding the pathophysiology, understanding if the diuresis or antidiuretic is appropriate or inappropriate, that will be enough to treat these patients. So there is no difference between adult and pediatric. Can we calculate urine osmolarity if measured one is not available? Yeah, you can calculate, but very important, you have to make sure that your lab also having the urine sodium and urine potassium. Why thiazide cause more hyponatremia in female more than male? I'm not sure, but you know, all hyponatremia is not only the thiazide-induced hyponatremia, more common in female than male. One theoretical contributing factor is the hormonal difference between the female and male. Other than this, I don't have any explanation. When to discharge patient who does have hyponatremia, first of all, make sure that the symptom will disappear. I think that is very important, and save level of sodium. As you see from the registry, that almost good number of patients, you know, they will be discharged when their serum sodium less than 135. So if you have somebody like with thiazide-induced hyponatremia, and he came with 110, and then his symptom improved, and then you discharge him is around 130, providing that you will give him a close appointment to measure his serum sodium in the clinic, it is fine. So the most important is the, first of all, symptom, resolution of the symptom, and number 2, stabilization of the serum sodium on discharge. If the formula is not accurate, what should we use? You don't need to use a formula, just you give the boluses. That's why in the guideline, it's very easy. If you go with the new European guideline, give 150 cc of 3% saline as a bolus, and then just monitor the serum sodium every 2 hours, monitor the urine output. If the serum sodium starts to go up, urine output is fine. If it is on the target, just continue to monitor. If you find urine output is going up, but the serum sodium is stable, you can give prophylactic DDAVB. If serum sodium shoot up, again, if it is on target, give DDAVB. If there is overcorrection, exceed the target, give DDAVB and give, hypotonic solution like the D5 water. There is no rule for sodium bicarbonate treatment of hyponatremia. What is the preferred rule for nutrition? Again, the oral route is the most important, and we see this one in tea and toast, especially in elderly, neglected nursing home. Sometimes we request to insert NG tube for these patients. If patient known chronic hyponatremia and serum less than 120, can we treat as acute? The problem if you treat as acute, so the risk of overcorrection, it will overcome, the risk of hyponatremia by itself. Because most of these patients, their brain get adapted to this level. So good number of them, just with the fluid restriction, they do very well. So we don't recommend to treat with hypertonic saline if the serum sodium, less than 120. I know in some of the books they said if the serum sodium less than 120, some books say less than 110. Even if there is no convulsion, if there is no coma, you can give 3% saline, but was stated very clear from the guideline. And when you read any review article that's recently published within the last 10 years, so they will go with symptom, acute versus chronic. Just to cut it short, when we say acute, most likely hospital acquired, because the serum sodium during admission and the serum sodium after repeated lab. Can we give Lasix injection in case of pulmonary edema with hyponatremia? Yeah. And that's why in heart failure, you can see in addition to fluid restriction, Lasix play an important role in correction of the hyponatremia because it is excess of water rather than deficit of sodium. And even sometimes in patients with SIADH, we combine the 3% with Lasix. Still an up-to-date recommended hypertonic saline infusion. That's up-to-date. Up-to-date is based on the author, so I don't go with up-to-date myself. That's why you have the expert, and that's why, when I give lecture, I don't go to up-to-date. Thank you. CKD patients are still depend on the urine electrolyte. That's very important. We don't go much on the urine electrolyte, so we go with the osmolarity because it will give me an idea about the true hyponatremia and about the function of ADH. So I don't go with your electrolyte. Urine electrolyte, it will give me an idea, but sometimes, especially for patients with CKD, it's not accurate. To differentiate nephrogenic syndrome of inappropriate diuresis from other type, just measure the ADH. ADH is undetectable. That's very easy. What are the preferred modality for treatment for cirrhosis or congestive heart failure? So this is very easy. So we'll start with the fluid restriction. If fluid restriction does not work, you can add diuretic for them. If diuretic does not work, again, we are talking about a chronic, you can add sodium tablet. If the patient starts to have severe symptom, you have to add hypertonic saline. If you have tolvaptan, also you can use it for these patients. But keep in mind, if you stop the tolvaptan, the serum sodium may go back to the baseline. Symptomatic severe hypovolemic hyponatremia after patient is stabilized with 100 cc, 3% NER, what will be our plan of admission? Which fluid to continue as inpatient? Hypovolemic hyponatremia is completely different story. So for patient with hypovolemic hyponatremia, that's very important. You will give him, first of all, you don't need to give 3% saline. So we don't give 3% saline for patient with hypovolemic hyponatremia unless the patient having seizure, coma, or respiratory arrest. you give them normal saline, and you monitor the serum sodium. You can give them like a bolus, then you can give them maintenance by calculating their free deficit. And then you monitor the trend in the serum sodium and the urine output. If you see the urine output increase or the serum sodium is going up, you can give them prophylactic DDAVB. So your aim for this patient is to reduce the urine output, because they will correct their hyponatremia because of water diuresis, not because of the amount of sodium in the 3% or normal saline. How to be sure if patient develop osmotic demyelination syndrome while patient is comatose and intubated? If you overcorrect, you can do MRI. So MRI is the diagnostic tool, but make sure to do it in the 2nd week. Which patient is candidate for DDAVB prophylaxis? High-risk patient for overcorrection, severe hyponatremia. Patient with severe hyponatremia, if you are afraid of overcorrection, you can give them DDAVB prophylaxis. Normal range for urine output to predict overcorrection. So usually I go with urine output. If the urine output going more than 200 to 300 cc per hour for 2 hours in a row, I give DDAVB, because most likely the patient will overcorrect. So I go with 200 cc per hour. That's why hourly measurement is very important. Or every 2 hours if the patient in the floor, but make sure to put condom catheter or Foley catheter. Most peripheral hospital don't have any urine chemistry, urine osmolarity. How we resolve this one? If they don't have urine osmolarity, I will talk about the management point. So again, in the management point, just go with the urine output and go with the serum sodium. Correction of hypokalemia induce demyelination. Not the correction of hypokalemia. The hypokalemia itself, it was a risk factor for demyelination, with or without hypovolemia. So the first case report of osmotic demyelination, it was pontine. That's why they call it central pontine demyelination. It was an alcoholic patient with severe hypokalemia with normal serum sodium. Do we replace sodium in ER or we admit the patient? A patient for sure need to be admitted, because the patient need frequent monitoring. Usually what we do, especially for severe, every 2 hours. If the patient having moderate hyponatremia, we measure it every 4 hours. How much sodium level should be 72 ml maintained? I do not understand the question. It should be on the target. It should be around 135. What is the cut limit of urine output? I think I mentioned this one. For hypertonic, we give it peripheral only for 48 hours, then may create some time. Again, so 3% saline, we don't give it in infusion. We give it bolus. Give bolus, then you can repeat the bolus. So don't go with an infusion. Go with bolus is much easier. After we give 3 boluses in the first hour for severe hyponatremia and the patient improve clinically and the serum reach target, what should we give the patient to maintain the target sodium in the next 24 hours? Fluid restriction. That's why we go with the cause. So we go with the fluid restriction. The fluid restriction, again, if did not improve, just make sure that your intervention is accurate. You can give Lasix, you can give sodium tablet. When we say fluid restriction, but not sodium restriction, you have to increase the sodium intake. You can give the patient sodium tablet, or you can consult your dietitian. If you don't have sodium tablet, they can give them high sodium diet. Most of the time they give them, Maggi soup. It contains a lot of, it is very salty. Yeah, what about correction of sodium by oral salt? Yes, but it's not for symptomatic acute who require 3% saline, but you can give it with the fluid restriction. It will work because it will increase the number of solute in the urine. So, but keep, if you are giving the tablet, the patient needs between 6 to 10 tablets per day. just to increase the number of solutes, so the urine output will increase. If you have it, you can use it. If I have hypokalemia and patient on 3% infusion, we will correct with 0.9 same fluid. If the patient, still can't take oral, you can give the potassium oral. You don't need to give it, IV. Or you can give it, in peripheral line, but we give it orally. And the role of sodium tablet, yeah, I mentioned sodium tablet, you can use it for the treatment. And it's like the urea, so it will increase the number of solutes, so it will cause water diuresis. When I will consider indamamide DC is enough for treatment to rule out other intervention. I did not get this one. Can we repeat the mechanism? I think because of the time, I think it's very difficult to go back to the slide. So thiazide-induced hyponatremia, just to tell you, so the thiazide work in the sodium chloride channel in the distal tubule, and it has no effect on the medullary osmolarity, because what pulled the water from the collecting duct is increase of the medullary osmolarity by the sodium chloride, sodium potassium 2 chloride from the thick ascending limb of Henle. When the chloride with the sodium going into the interstitium make it hyperosmolar, and under the effect of antidiuretic hormone, water will get absorbed. If you are using thiazide diuretic, again, there is no change in the interstitial or medullary osmolarity, so the water will get absorbed. Why there is little reabsorption of sodium? That's why patients will develop hyponatremia. Any problem of correction in the first 6 hours, then maintain the level of sodium. Just to let you know that, regarding the osmotic demyelination syndrome, it depends on the target within 48 hours rather than the target within 6 hours. So let us say that if you correct within 6 hours and then you maintain it, it is fine. Accurate specific gravity correlation with the urine osmolarity, you can correlate, but unfortunately difficult to judge. When we measure the serum sodium after correction, on admission, if it is severe, measure it every 2 hours. The easiest way, measure it with the VBG, because you will get the result very fast, and by lab every 4 hours. Second day, you can measure it every 4 hours, and then you can reduce the frequency. Antipsychotic induced SIADH, again, you will stop all the medication. You put your patient in fluid restriction if it is mild symptom. Most of the time it will work. If it does not work, you can increase the salt in the diet, or you can give the patient a salt tablet, or you can give the patient some sort of diuretic. So this is the way. So fluid restriction to start with. So fluid restriction, you can go back to the guideline. It is very clear. The guideline, and I did not put it, so they went in detail. It is free online. Just write on Google, hyponatremia guideline 2014. You will get detailed diseases, SIADH, cerebral salt wasting, adrenal insufficiency, hypothyroid, and so on. I have case of hyponatremia caused by tuberculosis adrenal. It was difficult to diagnose. Okay. We don't have DDAVB injection from, we have intranasally. Yeah, intranasally is effective. You can use intranasally. You can use intranasally DDAVB. If patient not indicated by 3% saline, but already received as given by ER colleague, how to manage this patient? Just monitor the urine output. Just monitor the urine output, because if he will overcorrect because of water diuresis. So the most important frequent measurement of the urine output and the serum sodium, just to make sure he will not exceed the target. By the way, if his urine output did not increase, he will not overcorrect. What is the relation between antidiuretic hormone and hyponatremia? I think I talked about this one in detail. Normal urine output for adult per hour is around 0.5 to 1 cc per kg. 0.5 to 1 cc per kg. and rule for 1.5 normal saline bolus instead of 3%. By the way, the 3%, when it comes to the lab, check with your lab, it's not a 3%. So it's very high concentrated, around 29 or 30% saline, and the lab, and the pharmacy will prepare it. So use the 3%. So 1.5 is nothing. So go with the 3%. The 3% communicate with your pharmacy, and the pharmacy, the one they will prepare for you. But you can give it through peripheral line. Patient who develops Secrecity-induced hyponatremia, you will evaluate later on if the patient in need for this drug, or you can replace it with a loop diuretic. In case 1, you have mentioned that the level of sodium I will consider 2DC indapamide, and the only intervention is needed. I will evaluate case by case. So if the serum sodium below 130, I will stop the indapamide, or the patient having symptoms. Why Vaptan cannot be used in hypovolemic hyponatremia? Because Vaptan, it will inhibit the antidiuretic hormone, and the patient will lose plenty of water in the urine, so it will worsen the hypovolemia. That's why it is not in hypovolemic, because it will worsen the hypovolemia, because one of the side effects is polyuria. The serum sodium of 130 indicate a chronic hyponatremia. Hyponatremia, it depends on the duration. If the patient came from home to the emergency room, or the patient admitted to the hospital and we see the drop of his sodium, so chronic hyponatremia is a duration related rather than a level. So if the patient more than 48 hours, if he's hospitalized or came from home, is chronic. Cerebral salt wasting. So cerebral salt wasting, it is like a mirror image of the lab of SIADH. Initially, it was diagnosed in patient with subarachnoid hemorrhage, but later on, in patient with any CNS problem, from infection to cancer to mass effect. So the patient will have true hyponatremia. The osmolarity will be low. The urine sodium also will be high, exactly like the SIADH. The osmolarity in the urine, again, it will be high. So it's almost like the SIADH. The difference is the volume status. The patient with cerebral salt wasting, they have hypovolemia. The pathogenesis is complicated. Part of it, there is an increased release of BMP, brain natriuretic peptide, and there is decreased sympathetic overflow. When there is decreased sympathetic overflow, this will stimulate the renin-angiotensin system and stimulate the uptake of water without sodium. So that's why they develop hyponatremia. To treat them, give them fluid, normal saline. If a fluid will not work, give them fludrocortisone. Fludrocortisone. I think Vaptan, I talked about it. Do we need to calculate sodium deficit? Myself, I don't calculate. I think I answered all the questions.
Fadel, I think you answered all questions. Many thanks for your detailing and for this nice lecture. We are on the time mostly, either the lecture and answering the questions. Again, I would like to thank you, Dr. Fadel, and we want to see you, inshallah, after Eid, inshallah, and كل عام وانتم بخير for all attendees and for you.
Thank you, Dr. Sabit, for making this event very successful. And inshallah, we'll repeat it. And I have to thank all the audience. Stay home, stay safe, and Eid Mubarak in advance for everybody.
شكرا دكتور.